Welcome to Season 3 of HealthStyle, the podcast from Kingsbridge Healthcare Group. Kingsbridge is Northern Ireland's largest private hospital group with hospitals and clinics north and south. Each episode of HealthStyle introduces you to one of the Kingsbridge clinical teams and asks real patient questions on your behalf. My name is Avril Keys and I'm here to host the podcast today. I don't have a medical background, but I have been a patient of the hospital myself back in 2021. I'm here to break down the medical terminology so that it's easy to understand the treatments and pathways available in each specialty. For this podcast, I'd like to extend a warm welcome to Mr Damian McKay, who's the Consultant General and Colorectal Surgeon at Kingsbridge Private Hospital. Hello Damian, thank you so much for joining us today.
Thanks for having me.
I wonder if you would start by telling me a little bit about your background and how you've ended up where you are now.
Sure. So I trained in general surgery in Northern Ireland primarily. So it was very early on in my training. I already knew that I was planning to go down a career route in GI surgery and predominantly colorectal surgery, probably influenced by a lot of the people that had been my trainers through the years. And as part of that, then I travelled to Australia. I was very fortunate. I was colorectal fellow in the Royal Adelaide Hospital, where I was able to then have very high volume additional training before coming back to Northern Ireland to take up a consultant post, both in the NHS and at Kingsbridge. And since I've been now working in Northern Ireland for about 12 years in consultant practice.
Okay, and so what does a typical day look like for you? Is there a typical day?
So I suppose what we do in a week is fairly standardised in that most colorectal surgeons or GI surgeons will split their time between outpatient clinics, endoscopy lists where we do diagnostic endoscopy and what we call therapeutic endoscopy, where we might be removing significant polyps and sometimes even early cancers, and then operating. So that would be the usual week. And in my practice, it's split between the Ulster Hospital in Dundonald, where I'm a colorectal surgeon, part of the colorectal team there, and Kingsbridge Private Hospital, where I work and operate and scope at the new Kingsbridge Diagnostic and Treatment Centre.
Which looks amazing.
It's fantastic. So it's been something which I've been very, very keen be developed within Kingsbridge, because there's a real deficiency in access to diagnostics in Northern Ireland. So the fact that we've been able to set up and build a very rare new build, purpose-built centre, which is something that an awful lot of trusts are struggle to do because of their buildings and design as such, has been fantastic. So at that centre, then we're able to see patients, offer them appropriate diagnostic tests such as gastroscopy, colonoscopy, and do CT imaging on the same day as well. So It's a very, very good team of staff that we have.
It's purpose-built.
Yes, purpose-built for the patient journey
fantastic.
through their attendance on that day.
Yeah, very good. It's clearly a unique setting at the King's Hall there, and I suppose it's a good time maybe for you to mention the 7-day pathway for red flag referrals that Kingsbridge has in Belfast. Can you tell me a little bit more about that?
Sure. So one of the issues that is present both in the NHS and in the private sector is how to quickly access diagnostic tests. And with cancer, obviously we want to make a diagnosis as quickly as possible, fully stage the patient, and then they're able to have clinical decisions made about what would be the best appropriate treatment for them. Yeah. So the new 7-day pathway that we're implementing at the King's Hall means that if for patients who are already in receipt of a red flag referral from their GP, that referral can be sent in to the team at Kingsbridge. A specialist clinician will review the referral, and if it's appropriate, then the patient can be booked directly to test within 7 days of receipt of the referral. And that's been happening now over the last number of weeks very successfully. And I guess the big thing for patients is whenever they're told by their GP that they've been sent in to a hospital as a red flag referral, then obviously there's a lot of worry involved with that. In reality, only very, very small numbers of those patients actually have cancer. And so I suppose the sooner we're able to make a diagnosis, the sooner the patient's either reassured or at least we find out what's going on and we can institute appropriate care.
Yeah, of course. And I suppose a good time to talk about some of the symptoms. I know that the diagnosing different cancers, upper and lower GI, is a big part of your job. And I know on the Kingsbridge website, and we will link to it on the information section for this podcast, there's an excellent diagnostic service which kind of outlines some of the areas of concern that might lead you to approach your GP. I wonder, could you just let me know what are the different symptoms that we should be mindful of?
So for lower GI or colorectal cancer, which is what I would primarily look after, the main symptoms are a new change in your bowel habit, particularly to looser stools that goes on for 3 or 4 weeks consistently. Blood mixed in with the poo, so if there's blood within the motions themselves that is persistent. Weight loss, so if you've new unexplained weight loss or new persistent abdominal pain. So those would be the main symptoms that patients would present with. We would then also get patients who have, for example, gone to their doctor for another reason and are found to be anemic. So patients who have what we call an iron deficiency anemia, because there's various different types of anemia, which means your blood count is too low. So for patients with specifically iron deficiency anemia, which your GP will be able to check for, those patients we would investigate on a red flag basis as well.
Okay. And are all those symptoms you referred to, are they all red flags in themselves?
So those are red flag symptoms. Nowadays in Northern Ireland, we're fortunate that GPs have access to a special stool test called a FIT test. And that is a very, very helpful test at helping us gauge how likely or not a patient might have a cancer. So patients who are referred in to the NHS red flag system will normally have an elevated FIT test in association with those symptoms, and those patients are more likely to have significant disease, and those are the patients that we're keen to get to their diagnostics quickly. In terms of upper GI cancer, the common symptoms are usually difficulty swallowing, so patients who have had trouble with food sticking on swallowing, particularly where that is progressive, where it's started off as minor symptoms and is getting worse and worse and worse. Significant weight loss, significant upper abdominal pain, they would be typical symptoms.
Yeah, but it's not always cancer, I suppose, and that's the
the vast majority of people who are referred in to exclude cancer, and in Northern Ireland every year there's in around 1,200 new colorectal cancer diagnoses. But every year in Northern Ireland there are many, many, many thousands and tens of thousands of red flag referrals, the vast majority of whom do not have cancer.
Okay. And in terms of people coming to have screening or tests done with yourselves, is it always cancer?
No, certainly not. So, as I said, the vast majority of people that we see don't have cancer. Many patients will have normal examinations, so either a normal upper GI scope or a normal colonoscopy. There will also be patients who have, for example, inflammatory bowel disease or diverticular disease, benign polyps or other conditions. And for those patients, then again, we're able to make the diagnosis. For patients with inflammatory bowel disease, then we can usually start them on some appropriate medication for that, which often transforms their symptoms very quickly.
Okay, so there is a pathway for the non-cancer.
There are very specific pathways and there are very specific management plans for patients who don't have cancer, and we would follow up patients then in clinic who perhaps haven't had a cancer diagnosis but are still having symptoms that we could improve through a series of either dietetic modification, medication, just general advice about how they go to the bathroom, because many of these patients will present with bleeding and hemorrhoids and pelvic floor conditions, for example. and many of those patients can have significant improvement in their symptoms with simple lifestyle measures and changes in habit per se.
Oh, that's great to know. So you mentioned hemorrhoids, rectal bleeding. So can you help patients who present with that?
Absolutely. So again, one of the commonest symptoms of bowel cancer can be bleeding from the back passage, but we also have a very large number of patients who present with bleeding which is actually from the anal canal. So this is usually bleeding because of hemorrhoids or piles, or because of anal fissures, which is a little tear in the skin of the anal canal. The stool test that I mentioned to you earlier, the FIT test, it's a very good test at helping us distinguishing between bleeding that comes from the bowel itself and bleeding that comes from the anus, which is the most common bleeding. So the vast majority of people that notice some blood on wiping or blood on the toilet bowl, they can get very anxious about that because they feel that it's likely something nasty. But the vast majority of those patients have actually bleeding from hemorrhoids or bleeding from tears. The stool test that many patients will do can help distinguish, but also seeing us having an examination, having a scope will help distinguish between the two. And at the time of either what is called a flexible sigmoidoscopy, which is a limited scope to look at the lower part of the bowel in patients with bright red bleeding, or a colonoscopy, we can offer appropriate patients treatment for hemorrhoids on the same day, and that's often done with a technique called rubber band ligation, which helps reduce the size of the hemorrhoids to help reduce patient symptoms, but only in conjunction with the patients themselves modifying their own habits, essentially, because as I say to patients, having hemorrhoids, it's not, or treatment for hemorrhoids, it's not like having your gallbladder removed where you do an operation, gallbladder's gone, that's it forever. With hemorrhoids, it's normal to have hemorrhoidal tissue. Everyone has hemorrhoidal tissue. It's simply that the treatments that we can instigate or do will help reduce the symptoms. It's not necessarily about taking hemorrhoids away, which can be quite a painful thing.
Okay, but so don't suffer in silence.
So
basically,
you don't need to suffer in silence, and also, by seeing someone who's expertise in both cancer and hemorrhoids and anal conditions, we'll often be able to give you reassurance that your bleeding is unlikely to be due to a cancer, and it's more likely to be due to the trouble that you have at the back passage.
Absolutely. So overall reassurance and then a pathway to help you with that, which is important. Presumably people can also go through the GP service in Kingsbridge as well, so you would receive your red flag referral from there too if you needed to. Yeah. So in terms of the diagnostics journey, and I suppose taking colonoscopy first, can you explain what that involves? Because I'm sure people would be nervous potentially coming in for one.
So I think the stigma around colonoscopy is significantly decreasing in the last number of years. Colonoscopy essentially is a diagnostic tool to assess the large bowel, and it's essentially, people call it a camera test or a bendy camera test, and what we need to do for a good assessment of the colon is to clean out the bowel, and that's usually done by taking some medicine, very strong laxatives, usually start the day before the procedure. So for many people that's nearly the worst bit of having a colonoscopy, because it's not the most pleasant thing to take, but it is only short-lived, and it does help us make a much more accurate assessment of the bowel. And it's not just cancers that we're looking for. There are many patients out there who will have polyps, which are benign growths in the bowel, and there are certain types of polyps which are more likely to become cancers with time. So when people come and have a colonoscopy, we'll be looking for those polyps and removing them where appropriate, and hopefully reducing the risk of those patients getting a cancer in the future.
Yes, but also potentially spotting a cancer and then getting someone.
Absolutely. So,
and then what is the pathway if you were to find a cancer?
So because of the setup of the unit at the King's Hall, we're fortunate that there's an on-site CT scanner. So for the majority of patients where appropriate, we're able to do CT scans on the same day or very shortly afterwards. It also is of benefit for the small number of patients who aren't able to have a complete colonoscopy. So about 95% of patients who come for a colonoscopy will have a complete test on the day, but a small proportion, for a variety of reasons, may not be able to have the test completed. And so what we will usually do in those circumstances is then do a completion CT colonoscopy, which often can be done on the day. And that means the patient then doesn't have to come back on another day, take medicine again to clear out the bowel, and have to have another appointment to make that final assessment. So it works very, very well for those patients.
And obviously doesn't have to wait
And
as
they don't
well
have
and
to wait.
extend the worry, I suppose.
Indeed.
And is there merit, and I suppose we're getting into screening, I guess, is there merit in having a colonoscopy if you've no symptoms at all?
So in Northern Ireland there is a bowel cancer screening programme, and that currently operates from age 60 to 74. We, as colorectal surgeons, we've been campaigning for a long time for access to screening for patients at a younger age, but unfortunately with the state of our public health system in Northern Ireland, that hasn't been possible. So certainly in other parts of the world, the patients who have a significant family history of colorectal cancer, there's various groups of patients who may be at increased risk and who in other parts of the world would have screening done from certain ages. There were programmes in the UK in the past to do a scope at age 45 or at age 50. But again, resource in the public system has meant that hasn't been available. However, at the King's Hall in the private system, patients who are concerned, who meet appropriate criteria, could be offered a screening scope.
Okay.
So that is one of the things that we can offer as well.
It's a great benefit. And I suppose there has been quite a lot of more public figures out there who have
Absolutely.
been very good to share their journey. I personally saw Ryan Reynolds and
right.
Rob McElhenney sharing their colonoscopies that they had earlier in the year, and I presume then that would maybe encourage people who wouldn't ordinarily come forward.
And certainly the incidence of colorectal cancer is increasing in younger people. And so I suppose we're very keen in those younger people in particular who either are at increased risk because of family history or who have symptoms to come forward, because there's nothing more devastating than a young person being diagnosed with advanced disease, which is much more difficult than to treat, where that disease might have been detected at an earlier stage where it's much more treatable.
And I suppose one of the reasons people might not come forward may be the fear of having a colonoscopy, or the embarrassment potentially about the part of the body that it concerns. Can you reassure people?
Certainly. So it's as I said, a test that has been maligned in the past, primarily because of the medicines used to clear out the bowel, but those have changed over the years and they're generally easier now to take. The procedure itself in most patients only takes 15 or 20 minutes to do. We offer sedation for patients so that they're comfortable during the procedure. If the number of patients who are in significant discomfort now having a colonoscopy would be much fewer, I would say, than in the past. And the team and the setup of the room and so on is very dignified. People aren't exposed unnecessarily. And very often nowadays we have patients who at the end of the test are sort of feeling, is that really it? Is that it done? It wasn't as bad as they thought it was going to be. So for most people, the experience of a colonoscopy doesn't have to be that unpleasant. It is a very helpful test, and certainly for those patients who over the years have been diagnosed with cancers that have then been operated on and treated appropriately and have had their cancers cured, they were very, very happy that they had their colonoscopy.
Absolutely. And is there any male, female, more of it seen in males?
So no, there's not a huge difference in terms of the cancer incidence for colorectal cancer between male and female. I guess in men, obviously, there can be a reluctance, particularly in Northern Ireland, to perhaps come forward with symptoms. And so sometimes we see patients who delay coming forward because of that stigma and because they're bleeding from the tail end, and because they're worried that there might be something there. But it's much, much better to come early, be reassured quickly, and for those very small numbers who actually have cancer, then be picked up at a much more treatable stage.
Yes.
So, delaying coming just increases your own anxiety, increases your own worry, and unfortunately can make the disease much more difficult to treat.
And we talked about this when we talked about prostate cancer in a previous podcast, about the importance sometimes of family members as well, just being aware of symptoms. So I suppose if we see it in family, it's good to be aware of it, particularly with husbands and wives, that you push them to have it done. In terms of the upper GI then, what kinds of procedures then do you do?
So for upper GI, it will depend on the symptoms. So the simplest one are those people having difficulty swallowing, and for those patients, a gastroscopy will, in the region, most patients with significant trouble swallowing will be referred directly for a gastroscopy.
So this is a camera.
This is a camera to look through the mouth, and it'll assess the esophagus, the gullet, the stomach, and the duodenum. And that test again is a very simple, safe, short test, which only lasts a few minutes in most people.
Okay.
Most people having that done simply need a little spray for the back of their throat. Some people will choose to have sedation if they wish. But most people, it's briefly unpleasant, I think is the way to put it, but over very, very quickly. And again, it can be used to detect other non-cancerous conditions that are causing the patient significant symptoms that can then be treated. We'll often test for example, H. pylori infection, which is an infection in the stomach, which can, in certain patients, if not treated, be associated with developing a cancer in the stomach. So there's a lot of information can be gained from those short tests.
Yes.
And then
a lot of reassurance.
And a lot of reassurance in the majority of patients.
And is that the main one then for upper GI?
Yeah, so there'll be other patients who have upper GI symptoms who, for example, might have pancreatic disease, pancreatic malignancy, because it can present with similar symptoms. And those patients often will have perhaps a gastroscopy or an OGD and a CT scan, which we provide at KDTC as well. And so a lot of those patients will have both tests done to rule out malignancy.
Okay. And if you have received the worst news, you're that small proportion, what is the next step then in terms of...
So the clinician who is responsible for your care essentially will then make the appropriate onward steps. So that may be being referred into a multidisciplinary cancer meeting within a trust where you live. Depends on, I suppose, who's looking after you. So obviously our team of specialists at the King's Hall will include both colorectal surgeons, upper GI surgeons, gastroenterologists, and as surgeons. For example, if a patient who was under my care had a colorectal cancer and we were planning to operate on them, then we would bring them into the colorectal MDT in the Ulster Hospital, and I would operate on them there.
Okay. And I suppose to reassure people where you can, I understand a lot of the procedures now can be done, with minimally invasive.
Absolutely. So for colorectal cancer, certainly the majority of patients are suitable for keyhole surgery, and most people now have a short stay in hospital. So for most straightforward colorectal cancer operations, lengths of stay are maybe 3 or 4 days. So a lot of people think that they're needing surgery means that they're going to be in hospital for a long time. But actually with both a combination of laparoscopic surgery or keyhole surgery and enhanced recovery protocols that we use to help people recover quicker, both before and after surgery, most people get home quite quickly.
That's great to hear. You talked about hereditary and potentially being at higher risk because of that. How strong is that?
So it'll depend on how many relatives you have who've had colorectal cancer and at what age they were diagnosed. So for some people, people can be worried, for example, if their granny had bowel cancer in their 80s or 90s, and if they're the only family member, then their risk is probably not particularly increased compared to the general public. Whereas if you had, for example, 2 first-degree relatives, such as your mum, dad, brother or sister, who were diagnosed at age less than 45, your risk would be increased. And a lot of those patients will have already been advised to have their family screened. And in Northern Ireland, we have a very good genetic service based at the City Hospital. So we would refer a lot of those patients to that service to give advice regarding family screening. We also now in Northern Ireland test all colorectal cancers that are diagnosed for genetic diseases. So those families who perhaps have had a couple of people within the family who've had bowel cancer, some of those can be part of a condition called Lynch or Lynch syndrome. That very specifically increases the risk of colorectal cancer within the family. And so now we're detecting more of these families that are at higher risk and offering them investigations sooner to help diagnose advanced polyps and hopefully prevent cancers in the future.
That's reassuring. And you talk about it's increasing colorectal cancer in younger people. And any idea why?
No one knows as yet. I guess as compared to maybe many decades ago, I suppose diets are perhaps not so good. So we know that poor quality diets, processed or highly processed foods, lack of fibre intake, all those things that perhaps in the past might have been better are now not so good. Excess alcohol intake, smoking, and so on. All of these things can increase the risk of you getting a cancer in the bowel. So, but why exactly, we don't know.
Okay. I'd like to make our listeners aware that you're not just Belfast based. Damien, you also treat patients in the Sligo
That's right.
hospital as well.
So in Sligo they also have an excellent endoscopy unit which serves very large part of the western part of the country, and we would have patients come to that unit from as far away as North Donegal right down to Mayo, Galway and beyond, and also many patients from the western part of Northern Ireland would come to that unit as well, because I suppose if you're living in West Tyrone or in Fermanagh, it is as handy to come, and you're going to have the same colonoscopy, the same diagnostic test that you would have in Belfast with another extremely good nursing team who look after you very well on the day.
Brilliant. Are you down there often?
I go down a couple of times a month.
Very good, very good.
I
always like to end the podcast on a kind of positive note, and you have alluded to this in earlier discussions. Could you give myself and some of the people listening hints and tips and things you do yourself for good gut health, bowel health that can help hopefully prevent a visit to you?
So I get an awful lot of it that you can control will be related to, I suppose, what you put into yourself. So it's going to be your own diet, and having a good, healthy, high fibre diet is going to be the number one thing that you can do, and having an active lifestyle, not smoking, not drinking too much. And in terms of, I suppose you hear the public health service recommending the 5 a day in terms of fruit and veg, so it's probably a good guide to use in terms of how much fibre you need to eat. And there'll be benefits in terms of that, and in terms of reducing your risk of getting colorectal cancer, also just general health benefits for you in terms of your weight, in terms of your gut function, even besides the fact that it might help you reduce the risk of getting a cancer in the future. Yeah,
and lots of stuff online about good and bad bacterias and probiotics.
Yeah, so the probiotics side of it is probably less cancer related and more gut function related. So I suppose a lot of patients that we see will have benign disease such as diverticular disease or irritable bowel, and for those patients who've got irritable bowel syndrome, then some of those patients will benefit from taking probiotics.
Damien, thank you so much for your time today. Hope you enjoyed listening to that, and please remember to subscribe so you don't miss future episodes of HealthStyle.